Dear friends, good evening to all. First of all, I want to thank Dr. Badri for giving me this opportunity to meet you all, of course, virtually, and share some of my thoughts on kidney stones. The disease is a common problem today, and 15% of the population will be affected by it sometime during their lifetime. It is probable that some of you or some of your relatives had this problem, and I hope this presentation will help you. This is a subject to which we are not exposed very much during our undergraduate and postgraduate training, unless of course you specialize in urology. Tremendous advances have been made in this field lately, and this has helped us to understand the subject in greater detail today. A variety of non-invasive and minimally invasive treatment options are now available, and not many, including doctors, are aware of them. To make it easy for anyone to understand about the disease and the treatment options available, we have created a special educational video at our hospital that should give anybody a better picture of the disease and how we deal with it. I would like you to see this video first. This will also help with the continuity of my talk and for the discussion that can follow. Video runs for 30 minutes. Some of it may be basic as it is made for both non-medical and medical people to follow. So please bear with me, and now I will start with the video.
Kidney stones. Vedanayagam Hospital presents Kidney Stones. Incidence. Kidney stone is a common problem occurring in 15% of individuals sometime in their life. Incidence is more in men as compared to women. But over time, the gap is narrowing, and nowadays more women are getting stones. In the modern era, incidence of diabetes and obesity are increasing at an alarming rate. Evidence shows that these diseases contribute to increased kidney stone formation and might contribute to increased incidence of stone disease in women. 3/4 of these patients will pass the stone either spontaneously or after medical treatment. The rest will need some kind of intervention. The common questions asked by most patients are: what is a kidney stone? How are kidney stones formed? What are the symptoms? Will I pass the stone without surgery? What can be done to relieve the suffering? Can we dissolve the stones? Can we flush out stones? Should I undergo intervention? What are the options available? Will I form stones again? How to prevent further stone formation? What are the dietary restrictions? What is a kidney stone? Kidney stone is a hardened mineral deposit or concretion which forms in the substance of the kidney or in the bladder. It begins as a microcrystal in the interstitium of the medulla, then developing as a collection of crystals and eventually into a stone over a period of days, months and years. What does kidney stone contain? Kidney stones are formed from substances like calcium, phosphorus, oxalate, uric acid and cysteine, which are normally present in all our foods, including water, in varying quantities and necessary for our body also. What are the different types of stones? A majority of urinary stones are of different compositions like calcium oxalate, calcium phosphate, magnesium ammonium phosphate, otherwise called struvite or infection stone, uric acid and cysteine. How are kidney stones formed? What are the steps in the kidney stone formation? Stone-forming salts precipitate out of solution in the urine and form crystals or nuclei. These crystals may either flow out with the urine as crystals, or crystals may grow and aggregate to form a larger crystal which may get retained in the distal portion of the nephron or in the interstitium of the medulla, eventually forming a stone within the substance of the kidney and later extrude out via the papilla into the renal pelvis and may come down and block the ureter. The basic principles in stone formation are essentially twofold. It is either supersaturation of substances that form stones, or it may be the absence of crystal inhibitors, or it may be a combination of both. In supersaturation, when the crystals excreted in the urine are more than it can dissolve, it leads to precipitation of crystals. Hence, if your urine contains more minerals than it can dissolve, it may precipitate as a stone. Where do the minerals causing supersaturation come from? It is multifactorial. It may be due to excess leak of calcium from the kidney. It could also be due to intestinal diseases resulting in increased absorption of calcium and oxalate. Or it could be also due to excess oxalate production in the liver. It could be due to parathyroid diseases. The parathyroid is a gland in the neck which controls calcium levels in the body. Diseases of this gland result in excess production of parathyroid hormone, which causes resorption of bone, leading to excess calcium in the urine. Another factor may be excess uric acid production. Actually, there is no single reason for stone formation, and it is by far multifactorial. Crystal inhibitors. There are substances present normally in the urine of all individuals which prevent crystal aggregation by repulsing one crystal from another crystal. Reduction or absence of these inhibitors is an additional and major factor in stone formation. The main crystal inhibitor is citrate, but there are other similar substances like magnesium, pyrophosphate, and many other substances present in the body.
What are the symptoms of stone? Stone in the kidney can produce loin pain, particularly on movement, but even a large stone could be surprisingly silent. If the stone migrates to the tube called ureter, then it can produce pain radiating from loin to groin, called as ureteric colic, and sometimes pain may go to the genitals. It may be associated with vomiting. There could be blood in the urine. There can be urinary irritation if the stone is in the bladder, or obstruction if the stone is at the level of the bladder neck, resulting in inability to pass urine, called urinary retention.
Will I pass my stone without surgery? It depends on the size and location of the stone in the urinary tract. Smaller the stone, better the chances of spontaneous passage. Normally the cutoff point is less than 5 mm. Chances of spontaneous passage of the stone below 5 mm is 77%, but it is only 46% if it is bigger than 5 mm. If the stones were to be in upper ureter at initial presentation, chances are only 22%, but it increases to 70% if the stone were to be in lower ureter. What can be done to relieve the sufferings? First and foremost is to relieve the pain, for which painkillers will be prescribed, which could be tablets or injectable depending upon the severity of pain. Hospitalization may be required in some cases when there is intractable vomiting or severe pain or fever. There is no need for routine antibiotics in all cases of ureteric colic, even if there is irritative urinary symptom which could be due to vesico-ureteric junction or bladder stone. Antibiotics are indicated only when there is proven urinary tract infection or associated fever. If patient persists to have pain, further treatment has to be taken, which could be medical expulsive therapy initially, and if it is not successful, then the patient can be subjected either to shockwave lithotripsy or other intervention. What is medical expulsive therapy? Normally, stone can get stuck at 3 narrow portions of ureter. First, being at the pelviureteric junction, just below the kidney. Next is at mid-ureteric level, where it is crossing the blood vessels, and finally, where it opens into the bladder, called as ureterovesical junction. Ureteric stones, which are smaller than 10 mm, can be treated with what is called medical expulsive therapy. Here, drugs that will relax the ureters along with painkillers and with increased fluid intake will help to push the stone down and expel the stones. This kind of treatment can be tried for a period of 7 to 10 days, failing which intervention is necessary to avoid damage to the kidneys in the long run.
Can we dissolve the stones? The answer is both yes and no. Of all urinary stones, those containing pure uric acid only can be dissolved with medications, but that too when the stones are very small. But uric acid stones form a very small proportion of about 7% of entire stone disease. Unfortunately, there is no miracle medicine to dissolve the rest of the stones as claimed by practitioners of alternate system of medicine.
Can we flush out the stones? Another common question asked is, can we flush out stones by the so-called glucose treatment? This is otherwise called as forced diuresis. Here, the patient is overhydrated with IV fluids and also given medicines called diuretics, Lasix, to increase the urine output and attempt to force the stone out. Occasionally the stones may pass out, but if the stone is tightly blocking the urinary tube, it may do more harm than good. In this situation, there is increased pressure in the kidney and ureter above the blocking stone, leading to leaking of urine around the kidney, a condition called urinoma. This can result in additional complications requiring surgical intervention. In the present era of medical expulsive therapy, this treatment is no longer recommended. If there is persistent vomiting, IV fluids may be given as replacement fluid only. Should I undergo intervention even if the stone is small? Well, sometimes yes, but when and where? If there is intolerable pain not relieved with painkillers, or there is associated fever suggestive of urinary infection, or if there is non-progression of the stone even beyond 4 weeks of medical treatment, or if there is increasing obstruction as seen in the ultrasound scan, or if there is obstruction in a solitary kidney, or if there are stones in both the ureters at the same time, or if there is decreasing kidney function over days or weeks, there is a place for intervention irrespective of the size and location of the stone. What are the interventions that are available? There is no one specific treatment for all urinary stones. Various treatments are available. First is extracorporeal shock wave lithotripsy, otherwise called ESWL. Second is ureterorhinoscopy through natural orifice with either a rigid or flexible equipment called ureterorhinoscope. A third procedure is percutaneous nephrolithotomy, a keyhole operation called PCNL. Very rarely, laparoscopy, robotic, or even the old-fashioned open surgery can be performed. Residual stones after all these above procedures is a real possibility and may need second procedure in a few patients. Again, I want to impress upon you at this stage that there is no one specific treatment for all urinary stones, and your specialist will decide what is the ideal treatment for your stone. ESWL, otherwise called as extracorporeal shockwave lithotripsy, is one of the greatest inventions of the 20th century. A common man calls it as laser treatment, but actually it is not laser, but shock waves from an energy source focused onto a kidney stone, which will fragment it into powder, and the fragments are passed in the urine. But not all stones can be broken with this equipment, and it has got its own limitations. The size of the stone, location, and composition of the stone determines the success of shockwave treatment. CT scan is an ideal investigation of choice, which will measure the hardness of the stone and guide the physician to make a decision. Ureterorhinoscope is an endoscope, and the procedure done with this is called ureterorhinoscopy. This could be semi-rigid or flexible. This instrument enables us to visualize the entire upper urinary tract. Stones in the straight portion of the tube called ureter can be tackled by semi-rigid ureteroscope. However, with the flexible equipment, it is possible to visualize the entire upper urinary tract and to treat the stones in the ureter and inside the kidneys as well.
Now we'll show you a small animation and video clippings related to these procedures done by me and by my colleague Dr. Vishwaru.
This is a IVP sequence. The patient has a large right renal pelvic stone. Left side, patient has 1 centimeter obstructing and symptomatic upper ureteric stone with lower calcium stone. I am going to show how I clear the left ureteric stone by using semi-rigid ureteroscopy. This is the endoscopic telescope called ureteroscope, which I am going to introduce into the urinary tube called ureter up to the point of obstructing stone. I introduce the scope through the natural orifice. You can see simultaneously the scope being passed through the ureter with the endo view as well as X-ray view and animation of the procedure. We go up to the stone. After visualizing the stone, I use laser fiber to break the stone. This is the laser fiber, which is very thin and can be passed through the endoscope up to the stone to break it into fine dust. Now you can see the laser generating machine with adjustable setting. By adjusting the setting, we can break any hard stone with this machine. Stone is being fragmented with laser into fine particles. Once we complete the fragmentation, the scope is withdrawn gradually, which is seen in the animation. This is a soft plastic tube called DJ stent, which is bent on both sides. I am going to pass the stent into the kidney over a guide wire. You can see it on X-ray being coiled up in the kidney so that it does not come down, and being coiled up lower down in the bladder so that it does not go up. This is done to facilitate passage of the fine stone dust in the matter of 2 to 3 weeks, after which it is removed.
IVP X-ray of this patient shows a stone in the middle calyx of the left kidney, which cannot be removed by the semi-rigid scope because of its position inside the kidney. Now I am going to remove this stone using flexible ureteroscope. This is a flexible ureteroscope, and you can see the instrument is flexible, and this scope can be manipulated inside the kidney by use of the hand lever as shown in my right hand. This lever can be moved with the thumb, and tip of the scope can be bent downwards in either direction, and also by turning the scope to the right or the left. The tip can be made to look forwards or backwards so that every part of the interior of the kidney can be visualized. Now in the insert, you can see the laser fiber at the tip of the scope, and the scope is being manipulated in either direction. Now I am going to do this procedure by passing the scope through the bladder and into the ureteric opening and up to the kidney to break the kidney stones into small fragments. I am passing the flexible ureteroscope through the ureteric opening, which you are seeing now, right up to the kidney. You are seeing simultaneously passage of the flexible scope both endoscopically and also on the X-ray as well as the animation. Now the scope has entered the kidney, and each and every aspect of the interior of the kidney is visualized. First, in the upper portion of the kidney, and now being moved into the mid portion of the kidney, where you are visualizing the stone also, and then the scope is again passed into the lower portion of the kidney so that entire kidney can be visualized. Now the stone in the middle calyx is again visualized and now fragmented using laser. Fragmentation is continued till the fragments are only about 1 to 2 millimeters in size, about the size of the tip of the laser fiber. These fragments are so small, they will be passed out spontaneously after such fragmentation. Now the scope is being withdrawn out. And I am passing a stent. This is done to facilitate the passage of fine stone dusts in a matter of 2 to 3 weeks, after which it is removed.
Next, Dr. Arul, Senior Endourologist, will be explaining the PCNL.
This is a large stone in the left kidney. This is otherwise called as a staghorn stone. It's occupying the entire kidney, as you can see it on this IVP X-ray. This stone cannot be managed with the previous said methods which go through the natural orifice. So this patient will require a different procedure called as a PCNL, and I am going to demonstrate this procedure now. After anesthesia, the patient is positioned prone so that the kidney can be approached from the back. Entire procedure is done under X-ray control. The required portion of the kidney is punctured with a needle and a guide wire is passed through the needle, and the tract is formed by a keyhole incision using metal and plastic dilators. Ultimately, the hollow tube called amplac sheath is left in position. Now I am passing an endoscope called nephroscope inside the kidney through this sheath to see the kidney stones. Through the telescope, I am passing a stone breaking device called lithoclast and break the large stones into small fragments. Now I am removing the stone fragments by using a forceps. A suction device is used at the end to remove all minute stone fragments and also any blood clot within the system. Having removed all the stone fragments now, tubes called a nephrostomy tube to drain the kidney is left behind for 24 hours. Before removing, we confirm complete clearance of the stones with an X-ray the next day. You can see the large amount of stone fragments in this case, which cannot be removed by other techniques.
So far, we have discussed the standard percutaneous nephrolithotomy for removal of kidney stones as popularized since early 1980s. Today, with the advent of miniaturization, much smaller equipments in the form of mini, ultra mini and micro equipments are available to do the same procedure with reduced morbidity. However, what equipment to use will be decided by the surgeon, depending on various factors, and also with his expertise with the particular equipment, with the ultimate aim being achieving best results with minimal morbidity.
After all the above mentioned procedures, there is a small chance of fever due to release of hidden bacteria inside the stone during fragmentation. This may need to be treated with higher antibiotics.
Will I form the stones again? Since kidney stone is a metabolic disorder, it is quite possible your chances of recurrence is about 5 to 7% in first year and about 10 to 12% by second year, and increases to 50% by the fourth year after the first stone experience. Why does this happen? Since kidney stone is a metabolic disorder in a given patient, tendency to form stones continues to be there, and unless proper care is given, it is likely to recur again and again. Probably the following X-rays and the video of an 11-year-old girl with bilateral kidney and ureteric stones who was treated by us will give you the answer. These are the X-rays of this girl with stones in both kidneys and ureter. Even after the removal of the stones by ureteroscopy on the right side and PCNL on the left side, there are small residual stones in left kidney. This is the flexible ureteroscopic view of the interior of the left kidney of the same patient, showing stones in various stages of development. Now you can see one stone which has come out and lying freely as shown in green circle, and there is another large stone which is buried under lining membrane shown in the red circle. There are many small stones buried under the mucosa as shown in the blue circle. It is possible to remove the large stone, but difficult to remove the small buried stones, particularly if these stones are present deep inside the substance of the kidney, which are not seen in the X-rays. Such stones will grow further and come out, producing the recurrence of stone at a later date. Development of stone at different depths in the substance of the kidney and extrusion is well shown in the accompanying animation which you have already seen. These buried stones are responsible for recurrence. How can I prevent further stone formation? When it comes to prevention of stone disease, one could do sophisticated and extensive blood and urine tests, which is called metabolic evaluation. There are specialized laboratories which are available in India now doing accurate kidney stone analysis and estimation of 24-hour urinary excretion of stone-forming salts, which help in decision-making regarding long-term preventive medical treatment. These tests are preferably done in patients who form recurrent stones or in children, as this is an ongoing metabolic problem. Such patients can be helped by long-term appropriate drug treatment. Unfortunately, these drugs have to be taken 3 times a day with their own side effects, resulting in non-compliance in most of these patients. However, considering the type of pain involved and possible kidney damage which could lead to kidney failure, it is worth doing these tests and take long-term medications. Specialized stone clinics where counseling is available for such patients is the need of the day. What are the dietary restrictions? Role of diet and renal stone disease, while important, is very difficult to answer. There are many myths relating to diet and kidney stones. The usual picture is that of a patient among the family of 4 or 5 members who continues to form stones repeatedly when all of them are consuming the same diet. If diet has anything to do with stones, then the entire family should form kidney stones. While it is true for certain familial disorders, in the vast majority it is not so. Nevertheless, restriction of certain foods will help to reduce the recurrence of stones. First item on the dietary restriction is quantum of meat, seafood and poultry consumed. Proteins and meat products will increase the uric acid and reduce citrate in urine, both of which are conducive to stone formation. Hence, it seems reasonable to reduce quantum of non-vegetarian food to 1/4 of your usual consumption. Next on the list of dietary restrictions is related to salt consumption. It is reasonable to take salt with cooked food, but one has to reduce the intake of added salts in the food like salt with curd, pickles and chips. Sodium present in the salt increases the excretion of more calcium in the urine, resulting in stone formation. The next dietary restriction is to reduce green leafy portions like spinach, broccoli to a minimum. These green leafy portions contain more oxalate, which is likely to bind with calcium to form stones. The most important point is to increase the fluid intake to produce at least 2 liters of urine within 24 hours. Without adequate fluid intake, no amount of dietary or medical treatment will help in reducing recurrence of kidney stones. There are lots of myths about vegetables with seeds like tomato, brinjal, lady's finger and others, whether they cause increased stone production. Probably this idea came from the alternate systems of medicine. Research today has found that tomato is beneficial for stone disease. Another common myth is related to banana stem extract and its ability to dissolve stones. There is no proven benefit.
The take-home message is, depending on the weather conditions, patients with kidney stones should drink enough water to produce a minimum of 2 liters of urine per day or more. They should restrict intake of non-vegetarian food, salt and green leafy vegetables. If the patient is young or getting recurrent stones even after treatment, such people should undergo a complete metabolic evaluation with special blood and urine tests. If the kidney stone is available, it should also be analyzed. Uninterrupted long-term medications may help patients with recurrent stones whose metabolic evaluation could pick up any definite cause for such stones. A regular medical follow-up with yearly abdominal scan, blood and urine tests may pick up stone at a very early stage, and early intervention could be done if necessary.